first of all, I would like to mention that this as it was a workshop. तो जब मैंने देखा ये हालात तो I'm just doing it as a presentation, but that doesn't mean that the team who was going to present were with me. I shouldn't mention and acknowledge them. Dr. Mukhtar al-Haq and Dr. Faraz, and I will request कि ये chair एक ऊपर ले आएं Dr. Faraz को. He is part of our team. He should be sitting here. So these are the people who have been working with me over many years, helping me to iron out my ideas, encouraging me, inspiring me. So this is the place where I work, Keele University. It is exactly between Birmingham, in the middle between Birmingham and Manchester, largest university campus, and I would like you to visit it sometime. तो अर्ली साइकोसिस है क्या? अर्ली साइकोसिस आई थिंक इट्स अ वेरी फेमिलियर कॉन्सेप्ट फॉर साइकेट्रिस्ट जो यहाँ पे बैठे हुए हैं. It refers to early course of psychotic disorders and specifically refers to prodrome and the period up to 5 years from first entry into the treatment for psychosis. Early psychosis या first episode psychosis की जो definitions हैं वो vary करती हैं a lot. Commonly accepted जो वो है definition है वो ये है कि जो first 5 years हैं including the prodrome, they are considered as early psychosis or first episode psychosis. और this is the and that has led to जो यूके की जो अर्ली इंटरवेंशन एंड साइकोसिस सर्विसेज हैं डेवलप दैट. इसके बाद जो मेरा लेक्चर है उसमें मैं अर्ली इंटरवेंशन साइकोसिस की सर्विसेज पे बात करूँगा. द कंसेप्ट इज़ वेरी सिंपल, जो कि स्लाइड में डिपेक्ट किया है कि यू सी के दिस इज़ द एज एंड दिस इज़ द प्रोड्रोम. और ऑलमोस्ट जब आप ये देखेंगे सो यू सी के जब फर्स्ट एपिसोड साइकोसिस में जितना भी टाइम गुजरता है, जितनी क्रॉनिक कोर्स होती है, आपका ये विंडो ऑफ अपॉर्चुनिटी है. ये तो एज के हिसाब से फर्स्ट 3 to 5 years ये आपकी विंडो ऑफ अपॉर्चुनिटी है साइकोसिस में, फर्स्ट एपिसोड साइकोसिस में, जहाँ पे यू कैन मेक द मैक्सिमम डिफरेंस. नीचे यू कैन सी द वेंटिकल्स, ठीक है. विद ईच एपिसोड, विद each day of untreated psychosis, the gray matter, the brain matter tends to be reduced, ventricles get enlarged, and so ये इस stage पे है chronic psychosis. Once you have 1 or 2 relapses or long period of untreated psychosis, you have lost the person. तो that is the concept कि इसके लिए. So I think I've explained that कि इस और दूसरा सबसे बड़ा मसला ये है कि फर्स्ट एपिसोड साइकोसिस अकर्स ड्यूरिंग द एडोलेसेंट, ड्यूरिंग द अर्ली ईयर्स. आपका मोस्ट प्रोडक्टिव ईयर्स हैं, ठीक. एंड देयर इज़ गुड एविडेंस फ्रॉम अर्ली इंटरवेंशन साइकोसिस को जो सिस्टमेटिक रिव्यूज़ हैं और मेटा एनालिसिस हैं ऑफ द कॉस्ट इफेक्टिवनेस. They show that if you intervene effectively, you gain years of gainful employment and education, and that make any intervention very cost effectiveness. उसकी जो cost effectiveness है उसकी डिटेल पे मैं बाद में बात करूँगा. So what are the consequences of delays? अगर untreated psychosis in time हो या long duration of untreated psychosis हो, there are increased rates of hospital admission, increased cost of management, delays in providing effective treatment, disruption, substance abuse, और ये सारे problems हैं. And suicide is of course a big risk. Potential, I think I've highlighted that. So if you are going to intervene अर्ली इंटरवेंशन साइकोसिस अगर आप कर रहे हैं, यंग ऑनसेट साइकोसिस की आप ऑप्टिमम मैनेजमेंट कर रहे हैं, तो उसकी जो वो है दीज आर द आउटकम्स कि जो आपको यू शुड बी टारगेटिंग, ठीक. जो सबसे मुश्किल चीज़ है इंटरवीन करना वो ड्यूरेशन ऑफ अनट्रीटेड साइकोसिस है, क्योंकि आपका एवरेज जो पेशेंट बाय द टाइम दे कम टू यू they have at least 2.5 years of untreated psychosis. That's very difficult to decrease. लेकिन व्हाट यू कैन डू, इंगेजमेंट आप इम्प्रूवमेंट कर सकते हैं, रीएडमिशन रेट्स को आप रिड्यूस कर सकते हैं, एक्यूपेशन एजुकेशन को आप इम्प्रूव कर सकते हैं, सब्सटेंस यूज। आई बिलीव कि इफ़ यू टारगेट द आउटकम्स इन टर्म्स ऑफ इम्प्रूविंग इंगेजमेंट, रिड्यूसिंग द एडमिशन रेट्स, improving the occupation, education, substance misuse, and decrease the self-harm suicide and decrease the offending rate. Of course, they tend to decrease when you intervene effectively, and improve the physical health. ये 4 या 5 आपके targets हैं for early intervention के you engage with reducing hospital. तो these are the outcomes for my year. I had the plan कि हम सारे ट्रीटमेंट गाइडलाइंस को डिस्कस करेंगे। ब्रीफली आई विल गो थ्रू दी ब्रीफ गाइडलाइंस, और आई विल एवरी गाइडलाइन ऑन मैनेजमेंट ऑफ फर्स्ट एपिसोड साइकोसिस, दे डील दी साइकोसिस इन 3 phases: द एक्यूट फेज, अर्ली रिकवरी फेज, एंड मेंटेनेंस फेज। आई विल जस्ट टॉक अबाउट द एक्यूट फेज, अर्ली रिकवरी, और उसकी बात नहीं करूँगा क्योंकि टाइम इज़ लेस। तो फार्माकोलॉजिकल ट्रीटमेंट, ये डिफरेंट गाइडलाइंस जो हैं वो डिफरेंट टर्मिनोलॉजीज यूज़ करती हैं। ऑस्ट्रेलियन सबसे जो वेल एस्टेब्लिश गाइडलाइंस हैं अर्ली इंटरवेंशन साइकोसिस की, वो ऑस्ट्रेलियन गाइडलाइंस हैं, बिकॉज दे आर मोर और लेस पायोनियर्स। ऑस्ट्रेलिया का ओरिगन सेंटर जो है, दे आर पायोनियर्स अर्ली इंटरवेंशन साइकोसिस। तो दे डिवाइड दी 3 phases: एक्यूट फेज, अर्ली रिकवरी, रिलैप्स प्रिवेंशन। अमेरिकन साइकियाट्रिक एसोसिएशन जो है उसको एक्यूट फेज, स्टेबलाइजेशन फेज और स्टेबल फेज में डिवाइड करती हैं। तो थ्रू ऑल फेजेस आपके जो टारगेट्स हैं वो जिस तरह मैंने मेंशन किया, इम्प्रूविंग इंगेजमेंट, इम्प्रूविंग फिजिकल हेल्थ, सेक्शुअल हेल्थ, वेरी इंपॉर्टेंट यंग एज, और ख़ासकर आपकी जो ड्रग्स के साइड इफ़ेक्ट्स हैं, दे इम्पेयर द सेक्सुअलिटी, और जो फंक्शंस हैं, एंडोक्राइन फंक्शंस, यू नीड टू कीप देम इन माइंड, फंक्शनल रिकवरी, रिड्यूसिंग द ट्रॉमा, इंटीग्रेटिंग द ट्रीटमेंट, फैमिली इन्वॉल्वमेंट, साइको एजुकेशन, सुसाइड प्रिवेंशन एंड सब्सटेंस यूज़। द चैलेंजेस, ये सारी जो हैं, ये आपकी जो गाइडलाइंस हैं, ये दे डील विद दिस। द चैलेंज इज़ कि हाउ वी कैन अडॉप्ट दीज गाइडलाइंस टू द पाकिस्तान सेटिंग। तो हमने एक इनिशिएटिव शुरू किया है, वी आर ऑलमोस्ट देयर। वी हैड अ ग्रुप ऑफ एक्सपर्ट्स, हमारी अपनी टीम जिसका मैं बात में वहाँ पे जिक्र करूँगा। वी वेंट थ्रू ऑल द गाइडलाइंस, और हर रिकमेंडेशन को हमने 3 उसमें डिवाइड किया। दोज विच आर नॉट अडॉप्टेबल, विच आर नॉट यहाँ पे इम्प्लीमेंट नहीं हो सकती हैं। Say for example, 12 sessions cognitive behavior therapy, that cannot be delivered. Those which can be adopted, like having brief sessions, 4 or 5 sessions, and those which can be implemented as such, like administering olanzapine. तो इन 3 में हर गाइडलाइन को हमने रिव्यू किया, उसकी एविडेंस को रिव्यू किया। I'll talk about this in my next lecture. And we have almost finished the first draft of guidelines. Then we are sending it to आप हमारे जो PPS के colleagues हैं उनको external review के लिए send करेंगे, and we hope to have the first guidelines for early intervention psychosis in Pakistan by hopefully February or March next year through adopting a very systematic process. तो मैं सिर्फ इसकी जो मेन चीज़ें हैं, ट्रॉमा है, what I would do is कि I will leave the presentation with the organizers here and it should be available. तो ट्रॉमा है, सुसाइड प्रिवेंशन बहुत इम्पॉर्टेंट है फर्स्ट एपिसोड साइकोसिस में, अर्ली उसमें। और जो सबसे इम्पॉर्टेंट चीज़ है, पीपल डोंट रियलाइज़ कि इवन क्लोज़ापिन के बारे में बट पीपल डोंट रियलाइज देयर इज़ अ गुड एविडेंस, शायद आप लोगों को पता नहीं है, होगा कि नहीं, कि अकॉर्डिंग टू एफडीए की एक इंडिकेशन है स्पेसिफिकली क्लोज़ापिन की, अदर दैन ट्रीटमेंट रेजिस्टेंट स्किज़ोफ्रेनिया, एंड दैट इज़ प्रिवेंटिंग द सुसाइडलिटी। ठीक है, सो द क्लोज़ापिन इज़ उसकी जो है ना 2 मेन इंडिकेशंस हैं, जो यूके में और यूके से जो रिलेटेड कंट्रीज़ हैं उन सब में सिर्फ ट्रीटमेंट रेजिस्टेंट स्किज़ोफ्रेनिया। एफडीए अप्रूव्ड रिकमेंडेशन है ऑफ द क्लोज़ापिन फॉर reducing suicidality and harm to others. And it's based on a very large trial, उसकी डिटेल में नहीं जाता. So जहाँ पे भी suicidality हो वहाँ पे और the clozapine can be considered. In fact, the trial, जिस trial की मैं बात कर रहा हूँ, उसमें the clozapine was used not just for treatment resistance, but for those people for to reduce the suicidality and the harm to others or violence के लिए. Substance abuse is a very big issue, first episode psychosis में, और unfortunately जो सब्सटेंस अब्यूज़ की ट्रीटमेंट है वो जनरली हमारी बहुत पुअर है, और हमारी जो साइकेट्रिक सेटिंग है उसमें हम सिर्फ सीवियर एंड ऑफ सब्सटेंस अब्यूज़ को टारगेट करते हैं, दोस्त जिनको सिर्फ सब्सटेंस अब्यूज़ है. सब्सटेंस अब्यूज़ कोमार्बिड with schizophrenia, with psychosis is often neglected. And when I talk about the substance abuse, the most common substance abuse is nicotine. That can be combined with the of course cannabis and other substances. So that उसको initial stages में target करना बहुत ज़रूरी है. And there are ways again the guidelines mention के किस तरीके से उनको वो करना है. As I mentioned, 60 to 70% people in first episode psychosis have the substance abuse at some time. Cannabis, alcohol, ये तो ज़्यादा fortunately alcohol का मसला यहाँ पे इतना नहीं है, लेकिन I'm seeing the encouraging trends over here. लेकिन जो commonest है at least nicotine और alcohol को cannabis को we must always be targeting. We should provide the assessment, supervision, advice, and individual treatment plans should be routinely implemented. Risk of violence 4 to 5 times likely, that should have been considered. Comorbidities, बहुत important है when we are treating the psychosis, especially in the first episode psychosis, we should look for the comorbidities. और उसमें comorbidities में it is not only the physical comorbidities, substance abuse, psychiatric comorbidities, generalized anxiety disorder, depression, they can occur concurrently, and they need the treatment on their own. And your treatment plan would need to be modified according to that. Pharmacotherapy के principles में से मैं इस वक्त सिर्फ दो चीज़ों पे बात करूँगा, and then I will finish for the question answers. दो चीज़ें. एक risperidone. The evidence is, quickly speaking, evidence is कि first episode psychosis में एक तो ये है कि lower doses work effectively, smaller lower doses work effectively. Having said this, that doesn't mean that you cannot or you shouldn't be given high doses, I mean the recommended high doses, therapeutic doses. And my strategy is always to exhaust one drug with good therapeutic dosages in earliest phase, 4 to 6 weeks, trial 1, trial 2, and then go for the clozapine without wasting time and without combining the pharmacotherapies. There is practically no evidence for the combination of antipsychotics. Side effects, start slow, go slow, as I mentioned. और बहुत इम्पॉर्टेंट बात है मॉनिटर एडहेरेंस एंड एड्रेस दी नॉन एडहेरेंस. इस ग्रुप में जो सबसे बड़ा इशू है वो है नॉन एडहेरेंस, नॉन एंगेजमेंट. तो दैट नीड टू बी टेकन वेरी सीरियसली. ओलेंजापिन के बारे में एज ए मेंशन के देयर इज़ जो मेटा एनालिसिस एविडेंस है दैट शोज़ के सेकंड जनरेशन एंटीसाइकोटिक्स आर प्रैक्टिकली मोर और लेस सेम except the risk of side effects. ठीक, जो न्यूअर एंटीसाइकोटिक्स हैं ल्यूरेसिडोन और एरिपेप्राजोल किसी हद तक है, और यहाँ पे अभी अवेलेबल नहीं है क्रिप्राजीन, दे हैव relatively good evidence for lower metabolic side effects. There are guidelines, I think there's one American guidelines which restrict the use of olanzapine in first episode psychosis because of the metabolic side effects. But at the same time, there are other guidelines which do not put that restriction. My own strategy is that I think, and I would strongly recommend that you should become very adept in monitoring the metabolic side effect and countering this. There's now very good evidence for metformin, both in prevention and the prevention of the weight gain as well as reducing the weight gain. The average weight gain reduction with metformin is about 2 to 3 kg over 1 year. And especially in female, it also helps to prevent the polycystic ovary syndrome और जो दूसरे उसके side effects हैं. तो recently, just last week, I think NICE has updated their evidence. मैंने अभी उसको सिर्फ शुरू cursory देखा क्योंकि it has just come last week. I'm going into the detail, but they are now generally recommending the use of metformin in prevention and the treatment, not prevention but the treatment. Prevention का मतलब ये है कि you start, which I tend to do now, you start metformin along with the olanzapine and risperidone जो सबसे highest हैं, और even मैं clozapine के साथ भी करता हूँ. Start along so that you prevent the weight gain. ठीक है, और ट्रीटमेंट में ये है कि you once the established weight gain. So this is where I will leave you. I want to have question for 5-10 minutes. As I said, the presentation would be here, and in the next lecture I will talking about कि हम early intervention psychosis की services को किस तरीके से establish करेंगे. Olanzapine, and just briefly I will talk about the risperidone. Whenever you are using the risperidone in young females, please be careful. जो उसके menstrual abnormalities होती हैं, they become very very concerning for the parents, और उसके साथ फिर जो hyperprolactinemia है, that can cause quite a significant problem. If you ask me, my two drugs are still first choice जो हैं वो still olanzapine, risperidone हैं. ठीक है, I usually tend to use risperidone more in male, olanzapine both male and females. But having said that, it's not that I don't use it. I do educate the parents कि menstrual abnormalities होंगी, but that they are not serious. तो ये दो चीज़ें माइंड में रखें. बाकी I think, as I said, कि ये सारी guidelines I'm just going through them. Treatment adherence की जो वो हैं, how you can ensure the treatment adherence. Just last thing about the use of depot in the first episode psychosis. Guidelines do recommend, may generally, if you ask my practice, I tend to avoid them in the very beginning. Not because they are not helpful. Simply, those people who lack the insight, complete insight, I would go for the depot. And once they are, like those people who have some insight or with state, I would still go for the oral. My only problem with the depot is, other than quite a few other, is that once you give the depot, unfortunately हम patient के mental state और symptoms की और functioning की जो वो है monitoring है वो छोड़ देते हैं. वो patient जो है वो regularly depot लेते रहते हैं. आपने देखा होगा 20-20 साल depot ही ले रहे हैं, कुछ भी नहीं पता है. So that is my biggest problem. That is not the problem with the depot, that is problem with us. ठीक, what I want to say is कि with the oral you titrate, increase the dose. One fails, go to other. That fails, go to the clozapine. Yeah, once a patient is stable on, say, risperidone or olanzapine, they still lack the insight. You feel the olanzapine and risperidone has not only achieved the good symptom control, but also good level of functioning, then you can consider depot. Okay. So that's all I have to say. Thank you very much.
But one thing that has been noticed, that metformin usage is notorious to cause cyanocobalamin deficiency, and patients with schizophrenia who are not able to give neuropathic pain complain. So how we can address that thing?
Yeah, I think that's a good question, and thank you for the compliments. I didn't say metformin should be used. I said I use it in my practice. The guidelines still are, they do not say should, they say it should be considered. So मैं थोड़ी सी, क्योंकि ये differentiation बड़ी important होती है, and when you say consider, that means कि you go and look for your own evidence. Metformin not only causes this, it causes quite a bit of stomach upset in the beginning. That is a big problem. And with the other drugs, that is it can, I think you can use the vitamins as a concomitant, but not in the very early stage, but in the later stage. I don't think it's with the regular use. Okay? Initially, I think you use it and then you monitor, and again I'm stressing, I think you become expert in maintaining, in monitoring and reducing the cardiovascular side effects. That means you understand how the metformin is used. Metformin uses, frankly, none of us is expert in it. I would strongly recommend that we become more familiar to it and study the side effects and see how these can be counteracted. There are quite a few. एक जो बड़ा फियर होता है कि मेटफॉर्मिन के साथ शायद हाइपोग्लाइसीमिया हो, हाइपोग्लाइसीमिया नहीं होता.
Excuse me, Dr. Shah, being a physician, metformin takes about 5 to 10 years to cause B12 deficiency.
Yeah, exactly.
So in few years it will do nothing, it will benefit.
As said, in the long term, you can supplement it. Yeah.
How long treatment should be continued for first episode psychosis?
I would simply say, जब आप diagnosis करें तो साथ prognosis भी ध्यान में देखें. Not every case is same. ठीक है ना. स्किज़ोफ्रीनिया की मैं मिसाल यही देता हूँ कि जो है ना, if you have, simply speaking, if you have strong family history, long duration of untreated psychosis, significant positive symptom, significant functional impairment, minimum 5 years, maybe lifelong. Acute onset, short, brief, at least you can give a try of reducing and stopping the drugs after 2 years. But that is just my practice. The guidelines don't say. Guidelines normally recommend in the first episode psychosis to consider withdrawal very gradually after 2 years.
Just to add a comment to what you're asking, I think with the psychosis, you can't be sure about the treatment because, as Farooq says, it varies from person to person. So when he talks about the first episode psychosis, the main catch is to discover and to find out when the first episode psychosis has started. Ideally, the evidence suggesting that the psychosis may have started much earlier. By the time you have the person with you or the person presenting to the facility, it's almost quite some time gone. So I think the mainstay is how early and how quickly can we identify and how early and quickly can we start the intervention. The outcomes, how long it's going to go, I think too many multiple complex factors which are implicated.
I have a question. What is the role of clozapine in duration of untreated psychosis for high achievers?
क्लोज़ापिन का या किसी भी एंटीसाइकोटिक का ड्यूरेशन ऑफ अनट्रीटेड साइकोसिस में कोई रोल नहीं है, क्योंकि बदकिस्मती से ड्यूरेशन ऑफ अनट्रीटेड साइकोसिस इज डिटरमिन्ड बाय द टाइम द पेशेंट प्रेजेंट्स टू यू. देयर इज सम रोल, I would say, in people with long duration of untreated psychosis, the prognosis is generally poor. And the treatment resistance, अभी हमने पेपर हमारा आने वाला है, we have developed a tool to identify treatment resistant schizophrenia and first episode psychosis at baseline. तो उसमें जो strongest predictor है वो duration of untreated psychosis है. तो if you see long duration of untreated psychosis, the clozapine should be on your back of your mind.
We are requesting my question is this, that providing with all the evidences, and it's coming, I think, every the second year trainee is now knowing it, that duration of untreated psychosis is something which is critical. And I think that the time has come that we need to have our own guidelines, evidence-based, because if you don't have the guidelines, so nobody would know it, that what to do. And when we are going to switch to the clozapine, and I mean, there should be like steps, evidence-based, so that it need to be then implemented, and then the services can be initiated. Thank you.
Thank you so much, sir. I'll request my chairpersons to give some brief comments about the session.
Okay, Aslanam, thank you. Actually, when you said about chairperson, I was still trying to find out who's the chairperson. But anyways, if you would like me to comment, and I know that people sitting in the hall when we started was 67, then they dropped to 48. I think at the moment they've again gone to 58. So I know that people are very interested in the tea. So I'll be very brief and short. I think starting from what Dr. Imran, a very good colleague, he talked about communication skills. Very important, very essential of what we say, what we do, and how we communicate. We used to talk of intelligence, then came the emotional intelligence. Now these days this is virtual intelligence, because most of our communication has gone e-communication. So you talk less to each other. We talk more on the WhatsApp, Instagram, and on the emails. So it's very essential and important to be careful what we write and how we communicate. So thank you, Imran. And then Professor Bashir talked about time management. I think that's a main problem for all of us. And so obviously with the conference also, time management. If we are not managing our time, that means we are not managing ourselves. So I think we do talk about it. The most important thing is we do understand from this session and try implement in our lives. And lastly, when Professor Saeed Farooq talked about early psychosis, I think that's a very emerging issue with us because we do sit in outpatients and we go to our inpatients. We don't realize that there's so many people in the community who are existing with psychosis. They may have a first episode psychosis, even not noticed by any health professional. So the question is, by the time they reach to a tertiary care facility, almost like a year has gone by, or even more than that. And once you start treating them, I think the outcomes, again, somebody was asking what are the outcomes, obviously the outcomes would become poor. So as Professor Mukhtar said, that we need our local guidance to let our younger generation, young leaders know how to diagnose, how to be aware about it, and let the community also know, the public sector, the public aspect of it, that they should also be able to know when it is emerging and what to do about it. So I think very important aspects which we have discussed, and I'm sure that all of you who go over from this session take that message on board. Thank you.